to give a short presentation on the gap analysis in the 7 domains of quality as per the SR that we have submitted this year in July.
Good afternoon. Very good afternoon to all of you. For the last 5 years, we are submitting our annual quality assurance report, and then we submitted SSR for the second cycle, that is the self-study report. And we are also continuously filling our credentials for the NIRF ranking, and we have the annual reports of KGMU and various departmental audits have come to us. So on the basis of that, we have found certain gaps which can help us to set our future goals. So therefore, just a brief that we have 125 parameters, the SSR, out of which 81 are quantitative and 44 are qualitative. So while we were filling the SSR, we came across certain areas where we can have a lot of improvement, which is possible. So criteria-wise, we are coming to curriculum. There is all the points, most of the points were okay with us. But as far as the regular revision of the program and syllabi is concerned, we are not that much updated with that. So we need the regular revision of the curriculum of all programs which are offered by the university, and 107 programs we are offering. As far as there is the possibility of introduction of courses is concerned, we are actually offering interdisciplinary course, but we are not much conscious about that. And there is a great possibility of introduction to disciplinary courses, which also should be sort of. In addition, those are running programs which we have put forward, but still we need value-added programs of requisite duration that is more than 15 hours. So now coming to the criteria 2, that is about the teaching, learning and evaluation. This criteria, one of the criteria in this is about the enrollment of the internal students. And now, many of the times we are unable to show it that how to get this, but there is possibility that we can enroll the PhD students from the foreign nations. Also, there is no intake in and BTCC, and those are the areas for students to join with us. There was need of factoring of the students. Right now, many of the departments taking the independent effort. University has a uniform policy for practicing the needs of the slow learners. So this is also finds a gap, and we should try to fill this. There should be a well-framed uniform policy for all students. In addition to it, we were having 68% of the last 5 years on an average. We should try to look for the timely recruitment of the faculty members. So we found that all our faculty members who are dealing with the UG education are not well trained in the medical education technology. So I need that all faculty members, 100% faculty members, should be trained in the medical education technology, and it should be mandated from the institution. We put conscious efforts to increase students' methodologies for students. And finally, in the area, all the teachers must be well trained for development. We are lacking a robust mechanism for the curriculum mapping, and that has to be developed in time. Coming to the research criteria, where we were lacking or were not able to get the marks was an existing and full potential of the innovation and entrepreneurship and innovation system, and probably we are in process to fill this gap. We have to have an industry academia collaboration so that we can come up with the valuable startup for the societies also. In addition to it, we should have a constant focus on increasing the workshop and seminars for the IPR, that is intellectual property rights, and in relation to the research methodologies. Definitely increase our number of patents and copyrights, and also a conscious effort to increase our publications in the UGC approved journals. Institution has developed its IPR, but we still need proper consultancy policy for this. In criteria 5, we are having a very good status, except for there was something known as the hospital accreditation. We accredited our labs, but we need to accredit it in a stepwise fashion our hospital services. We need to build the e-content facility in our university. Coming to the criteria 5, we do not have the planned modules for the skill development of the students, other than what are regularly done in the courses. So we need to develop the skill development schemes. We should also have our students the career advancement courses or some mechanism where they can help by guiding them in advancement. We should also help our university by getting placement data, both in terms of higher education and their placement, where we are still lacking, and it is a tough work to acquire the data. In the leadership, all the points were well addressed, except for the same, as I told earlier, the faculty development faculty development programs. One more area in the leadership and management was the performance appraisal for teaching and non-teaching staff. We have this mechanism, but it has to be converted into an outcome-based. Finally, in the criteria 7, that is the institutional values and practices, there was one time where we had the code of conduct for all stakeholders. So there are certain areas, like for faculty, we have the prescribed code of conduct that has to be built and has to be implemented. And all the stakeholders, whether they are students, employees, or faculty, they all have to be sensitized regularly for those things. Where we were lacking, we were unable to put the evidence for them. So on these basis, and we had certain recommendations from the Raj Bhavan. There was a visit to the Chandigarh University. So they recommended certain which has to be taken by our university to improve our overall performance, in which certain recommendations are, I was putting that, like establishment of chairs. This is one profile parameter of every university that we have to fill at which chairs they are holding. So we are lacking this. So departments must be promoted to hold the chairs in the fields. We have financial benefit, but it gives credit to the institution. Secondly, profile-related recommendation. We were not able to fill the column of the visiting professors and professor emeritus. Our national and international professional contacts may be offered the title of visiting professors. The concept is helping in building collaboration and may also help us in increasing our position. A retired professor may be given the title of emeritus professor, so which is like associating the past with the present. This idea was from the we should encourage our students to provide inputs for research projects, and we can build an idea tank or the think tank. And research topics must be of social utility in alignment with the SDG 230. We should encourage patent suggestions, guidance, handholding, motivation, and I think that will be taken care by the innovation systems. We have to do the efforts to establish the cluster innovation center. And as I told earlier, that we need an active collaboration with industries and especially with the developing nations. We have to refocus ourselves purposely because this goes in long way in improving our ranking. Because the developed nation, they don't put us. But if we are going to the Southeast Asia countries and collaborating with them, it will help us getting that advantage of taking for our ranking. We have to develop methodologies for imparting value-added courses, moral values, and social ethos to the students. And there should be properly formal courses for the same. Each faculty, as well can medical, dental, nursing, and the paramedical, one program can be run by team. These programs should be of more than 15 hours, and they can be offered twice a year. And they should be added with the registration process. They have a proper documentation and certificates. As far as the Green Campus is concerned, this is the recommendation from the Raghavan also. We should try going for the paperless offices and the treatments. There is a special recommendation for requirement from the Department of Medical Education that it should take active participation of all the faculties in a step-by-step fashion so that they know about the implementation of the new curriculum development and evaluation, new teaching methodologies, development and delivery of e-content by using the institutional learning management system, newer assessment types. Universities should take an active initiation to promote the application of such projects in university where we are lacking, to conduct regular monitoring of the feedbacks, to monitor feedback of teachers and conduct medical education quality improvement workshop, webinars, conferences regularly. As I said, need to provide data of placement and details of all students who joined KGMU. And to establish contact with national and international alumni and to tap alumni sources for institutional upliftment. These were the areas having a long gap. As a student in progression, it's a matter of pride that we have started the implementee program, but it shouldn't be like only on paper, but it should be actual. To guide the students for competitive exams and career progression should also be taken care of. The feedback system, I must tell you that it has been taken by the IQAC. It's in infancy. It's a proper, thorough support from all the officials of the university. And finally, most important thing, what we were struggling at IQAC was the collection of the data. It was from the day one. I think all the criteria heads would realize that the collection of the data is like mammoth task, and we are not getting that. Rarely we are sending the defaulters list and asking them. So we need a solution for that. The monthly or quarterly mandatory data submission from all the faculty members and departments or units or offices. And there should be a single window data portal, because we can just see that it is required from NAP, promotion, annual report, research showcase, best department, best clinical audit, academic audit, and for the APA. So we can get this. We at IQAC are ready to support to development of this by putting our all efforts to give the baseline data, and then it has to be ready because this is a lot of time taking procedure and everybody gets like so much disturbed by this by collecting data and sending data. So that's all from my side. Thank you so much. Happy to meet you all.
Thank you, Dr. Anita. You have highlighted very well the many strides that we have taken in the different areas of quality and establishment of quality protocols in the university. Some are baby steps, but yes, there are different areas where we still need a lot of improvement that highlighted. Our next speaker is Professor A.K. Tripathi, sir. I is the Dean Academic. I invite you, sir, to give your suggestions and strategies for achieving quality medical education.
कीबोर्ड चाहिए सर को कीबोर्ड दे दो
Honorable Vice Chancellor, colleagues, good afternoon. This suggestion and strategies for achieving quality medical education at KGMU. Recently, there has been revamped in medical education technology, and also there is a paradigm shift in the way we are students. Introduced this competency in 2019, and NFC is implementing since 2020. This, they are trying to ensure uniform assessment, also assessment, and ensure common and standard medical graduates all over the country. We are implementing bias 2019 onwards. This is a It's also very important. You know that there is a rising medical tourism in India, so we have to meet with the global standard. That's how they are trained. Also aligned with our evolving and our of cultural and other issues. So we have to align our graduates in such a way that they are also relevant as well as global standard concern and also address our local health needs. You can see the shift in the paradigm shift. Like initially it was traditional, teacher centric and content oriented, and the method is student centric and outcome oriented. We have strength and we have opportunities that we have to face at our KGMU. We have the best students of the state and country, well qualified and paid, and also and encourage digitalization. Also, we have high participation, and we are regional center for technology. So these are our we can have. But there are challenges and challenges. Higher student to teacher has presented 68%. 32%. It is very hard to see that there are 18 students. The ratio is almost 1 student. It's not. It's micro. Only 2 or 3 teachers for teaching the particular teachers. So ratio, actual ratio is very. So we have to take this very seriously. Who are scientific teaching, and also paucity of design. Most is clinical for teachers to prepare, align, and also a good time for teaching and learning. Inertia to adopt new changes. It's old habits die very hard. Teachers, and they want to follow the old pattern. So there is certain degree of inertia. In-educate training among faculty are designing and implementing the CV curriculum. So we have to strengthen the training program also. Changing learning methods and technologies, including augmented intelligence, simulation, robotics, all those things. So one has to adopt with the changes we are that is the basic exam. And we have to prepare our program. We train our students that they face successfully and the national exam once they finish final year, and also train them clinically and prepare next PG once they finish. So these are 4 core areas where we can strengthen ourselves to meet challenge: faculty development, curricular enhancement, structure, and governance. Faculty development, advanced formal teacher is must. There are various modules defined by National Medical Commission. We offer this master program in health professional, and there is a Federation of Advancement of International Medical Education Research. This is also fellowship offered by Interagency. So these are different courses, and at least 5 to 10% junior and mid-level faculty should be trained in these advanced courses every year. We should also promote international observership, at least among faculty members, so that they can go and see how these programs, like KGMU and other programs, are successfully being run, and they will get stimulated also to come back and start the program. So observership is very important step in that regard. Continuing medical education workshops. Generally, we assume that CME is based on the core CME in cancer, CME in surgery. CME also should be organized on this particular subject, like teaching and learning methods, formative audit, formative assessment, to set they will be applied. I encourage and felicitate faculty research achievement for as a popular teacher, for book writing, but probably we are like that we should also identify, recognize, felicitate those teachers who are contributing significantly in teaching and learning methods. Enhancement. We should prepare ourselves so that we prepare our students for next PG. And also we can expand our curricular ambit by introducing interest-level professional activities. This is called EPA. It is a graduate for some basic competencies to practice clinical in patient manner in a given, at least in an independent way. So this students complete and some learning in communication self. And also there is what is scope for electives, including in the program. We are offering electives to investigators so that they can go outside and share the knowledge. Research as part of curriculum for undergraduates. Infrastructure classroom, not really smart. This is communication. We see in the market, the student listen. Student like sitting in the last bench. We communicate. So there must be inter-classroom. This very innovative classes and data more labs. And also use learning management systems. There is an online platform where can the lectures and also assignments to students. So we should also, I think, do we have it? Not yet. So we should think up in that line, learning management system. This is very commonly used in other disciplines like engineering colleges and degree institutions. Components. Feedback is very important. By feedback, we know where we are, and also we know how to improve. We must strengthen mechanism of feedback and responsiveness to feedback from students. Strengthening curriculum implement monitoring. We have very good curriculum committee faculty from our institute, but we should also have a committee who could monitor the curriculum implementation in the university. And also, of course, teacher issue. Thank you.
Thank you, sir, for highlighting the need for the faculty to adapt to the changing teaching learning methodology and to train our students so that they are able to meet the mandated national requirements. I would now request Professor Shaili Avasthi Madam to give her suggestions and strategies for achieving goals in the domain of research, as Dr. Balram Bhargav is unable to join us for this meeting today.
Thank you very much, Dr. Bhalla and Honorable Vice Chancellor, sir, Pro Vice Chancellor, Dean. I have not formal presentation because I wanted to be proactive in my response. And with me, I would like to extend my ambit a little beyond research, primarily focusing on research, because so many things have been said which are close to my heart. Now, as you go one by one, it was pointed out that we don't revise our curriculum. And that was a point which was pointed out. However, I strongly feel that revisions are done every year. And what we are lacking is documentation. So what I would here suggest is that yes, we have a curriculum committee in the institution, but within the department, there should be a nodal for the curriculum committee who is responsible to document and submit it so that that is ready, because every year when we do lectures and clinics, it's done. Second was, which I wrote, was teaching learning, the international student saga. We are governed by the ND, we are governed by the Dental Council, etc. But we have now post-COVID a very open field, and under the new education policy, in which we have to perform, we can start online courses, hybrid courses, within association with international institutions with whom we have a MOU. That can be done on this we have in core competency. For example, tropical disease courses, tropical disease courses, or in response strain settings. How can we do it? This is our core capability. We have to maximize it before the next accreditation. I will talk about the research later once I finish other things. Now, issue is there, I believe, the re-employment can be upgraded to re-employment with the emeritus status, which would make the people feel much wanted by the university. Now, we have things like, I would not talk about Idea Tank and Green Campus, but another close topic is medical education. Now, in medical education, yes, everyone should know what is medical education. However, it is not an institutional mandate to attend these courses, 2 courses per year. We are willing and have conducted medical education course in-house beyond the NMC course on various topics like integrated evaluation, postgraduate students, student teacher. But there should be, I request, unfortunately, a mandatory attendance to at least 2 medical education courses besides the NMC mandate, so that our faculty takes up. Because if there is a target, it is fulfilled. If there's no target, it is not fulfilled. Now, the other thing is, same for MHPE, which we are running, we have started, and I may not be wrong when I say we are the first university to have started this Masters in Health Profession Education. It ran for 1 year, the other years, sir, there were no takers, because again, there has to be an incentive to do a postgraduate course after your MD/MS, after you've become a faculty. And for the last 2 years, I am getting very good faculty, not only from our institution, but from RML institution, they are coming and registered. RML institution, Ramanon Loya. So if we could motivate and give some incentive to our own faculty to join, then we have 30 seats per year. 30 seats is what we said. We can't take more than 30. We said 15 internal, 15 external. We said for 15 internal, there will be no exam. But we pointed out how we will prioritize if there are more 15 applicants within our statute ordinances which have been approved by appropriate authority. So I would request the administration to look into this and help us. I liked what Dr. Tripathi said very much. One more thing, sir. For slow learners, our VC sir said to start MOOC. We had an internal discussion and we are prepared with the people good in IT in our medical education to begin MOOC in a way. And that MOOC would be linking with those who are giving MOOC. For example, IIT Kanpur is giving MOOC. We have a workshop orientation towards MOOC and we launch our MOOC platform after registering in the Swayam portal. Because without registration in our Swayam portal, we cannot log in and put any content in the national portal. So any content we develop, it has to be vetted by the national people and then that will be put on the Swayam portal. Now, data collection cell on what Tripathi ji said was very good. We definitely, sir, for many years I have been saying we need more faculty. Each unit has 3. 3 is for clinical work, but we need 3+1, if not 3+2, for teaching and research. And by rotation, if there are 4 of us, 1 month I do the clinical, I don't do the clinical, I do other. Next month, you don't do clinical. Next month, you don't do. This is specifically for clinical departments. Whether it will translate to non-clinical or non-clinical, I don't know. But at least for my department, we definitely require that. And when the faculty seats were enhanced, I was very happy that now our units will have at least 4, if not 5. Now, sir, coming to research with the SDG 3 and the work you gave me, I'm sorry I did a lot. Now, I was told that for 2027, what would be the 2 targets I would like to put, aspirational? I would say the targets, we work as a country, within the country, state, within the state, our institution, then our strength is our departments. So the targets should come from the department, not from the university. The university will give a broad guideline. And if you see the SDG 3, that is good health and well-being. So why not each department be told to select and prioritize one area in their discipline for research and implementation of preventive and curative services in partnership with the government, and with that in partnership with each other. And there should be a 6 monthly target which can be evaluated. which the IQC will do or the department should do, but it should be targeted and focused. Because see, departmental meetings have to be held every month. In those departmental meetings, these are the things to talk about. So that is one target. Departments taking the ownership, departments prioritizing, departments focusing the research, and the next step would be the intramural grants will be to support the priority areas of the department, because then the university will showcase its mettle and its purpose to do the work. The second priority which I placed, and it's in sync with what Anita said, was publication patent startups. There will be there should be departmental criterias. The department should make realistic criterias and stick to them. And if they falter, have their SWOT, but catch up with the lab within next 6 months or so. Which means if you have to have publication patents and startups, you have to have projects coming in. Needless to say that the departments will function with a supportive institutional environment. Thank you very much, sir.
Thank you. Thank you, ma'am, for your suggestions. Our next speaker is Dr. Yashpal Bhatia, who is our expert member on this committee. He is the managing director at Estron Group, which is a leading healthcare consulting organization in the country. He is a well-known expert in hospital planning, design, and management. To his credit, he has established more than 50 reputed healthcare establishments, including medical colleges, super specialty, and multi-speciality hospitals worldwide. He has led the quality movement in the healthcare sector as chairman of the National Task Force constituted to launch the NEBH in India. He has also been the principal consultant to Medanta, Rajiv Gandhi Cancer Hospital, and many other prestigious hospitals. We welcome you on board, sir, and we'd request you to kindly share your suggestions and strategies for developing entrepreneur and managerial skills for our medical students.
Yeah. Thank you so much, ma'am, for the kind introduction, and regards to Honorable Vice Chancellor General Bipin Puri for inviting me to this August meeting and to be with all of you on this day for sharing my thoughts. Of course, I'm not as enlightened about the academic activities of the KGMU, which is on the forefront of the nation in building up, the overall ethos of medical education. In fact, institutions like KGMU are the ones which are play the leadership role in creating that ethos. And I would start my comments based upon that point of view. I feel that till date, we are still, working on the global platform in a way that anytime when we are talking of guidelines or protocols or anything in the standard treatments, first I'm talking about the clinical part of it, we refer to American guidelines, we refer to British guidelines, we refer to whatever it is. I've worked a lot in the field of oncology, and I feel, anytime we sit in the tumor boards or meetings or discussions, we are always talking NCCN guidelines. Or, for this particular treatment, these are the Japanese guidelines, or these are... With the kind of numbers we have, the kind of treatment that we provide, the level of facilities we had, I think the time has come that institutions like KGMU play a role. That why I can't say these are the KGMU guidelines, or why I can't say these are the national guidelines which were initiated at KGMU and they have now become the standard guidelines. While I was at Rajiv Gandhi, I was heading that institution. We started putting our own effort on creating the institutional guidelines for each type of cancer. It took me almost 3 years till we could create some kind of standardized institutional guidelines. So I have a very strong suggestion that, if each department can recognize 5 most commonly treated diseases in that particular department and work on this, on creating the standardized guidelines, which later on can be adopted in such a way that they may become the national guidelines tomorrow for the country, the Indian guidelines. Because we do understand that, come what we say, the many of the international guidelines, because of our ethnicity and because of our many other socio-economic factors may not fit the guidelines which we are supposed to. And many times our physicians feel that constraint. I remember of a VVIP patient where they were talking us the guidelines which they were following from Sloan Kettering, and our local physician team was actually of the opinion that these are not the guidelines which is applicable for this patient. We should probably go in the clinical way. But being a VVIP, the whole family and many of the political, socio-political structures, they said no, we have to go further. So we really had to ask the family to write down that though we physician team over here doesn't agree with those guidelines, but we'll follow the Sloan Kettering guidelines. There are institutions like Medanta, when they came up, they all thought that we should become the Sloan Kettering of this part of the world. So actually, they might have become the Sloan Ketterings, but when we go to academically, I think institutions like KGMU has to play that role. So, Honorable Vice Chancellor, sir, one of the suggestions I would make is that maybe this is one area where the clinical protocols for common disorders could emerge as one of the guidelines for the next 5 years. Similarly, on the research projects, the unique research projects, I had been a visiting professor to University of Oslo, and where the departmental grants were in fact related to number of PhDs they have produced per year. So somewhere down the line, we need to create that target for each department. That this is the target for each department where research projects. Even in the smaller hospital, when we provide them consulting or when we advise them on NABH accreditation, the simple thing which we do is that each department will have at least 2 quality improvement projects per year. If there are 20 departments in a hospital, and even if there are two projects per year, that means ultimately at the end of the year, they have 40 quality improvement projects which they have implemented. They may not be very complex, they may not be very complicated, but then at the end of the day, they have resulted into some kind of improvement. And that's where I think if we put a kind of a target that each department has to have, and ultimately success of those projects is the one which brings the appraisal of that particular department. I of course don't know the way the U people function or KGMU functions, but this is what University of Oslo did, that for number of PhD produced by each professor or each department was one of the evaluation criteria for the funding of that particular department. Now coming to feedback, there was a question which was raised on this, that the feedback mechanism. The structure of the feedback mechanism has to be very, very important. We have a number of global practices which have been there, and a lot of evaluations have been done. One of the very popular and very commonly practiced evaluation methodology in the Scandinavian countries is that the director of the institution holds about 25% weightage. The co-faculty, they hold 25% weightage, and the students hold 50% weightage. Now, how much weightage in our scenario it should be, that's something, obviously with your internal experiences one can say, but these are the 3 major stakeholders who will be able to determine, some of the targets could be built around. Coming to the non-medical and non-clinical functions, I think one area where we lack a lot is the administrative training, the managerial training. Whether it is at the professor level or whether it is at the level of the undergraduate students. We are supposed to administer the department. We are supposed to manage the department. But are we trained to manage? We do it because we have been entrusted to do it, and we do to the best of our capability. I'm not saying that people don't put in their best for the managerial functions. But at the same time, are we trained to do that? So maybe, the governance, the principles of governance of healthcare organization or the department could be incorporated as an activity where people could be trained at all levels, right up to undergraduate level, because you will understand that even the students who pass out, when they go to a primary health center, the management of the primary health center is also a requirement. They have to understand how to manage that. They are trained to write a prescription, but are they trained to manage that? Whatever happens over there, they have to do a lot of reporting, they have to do a lot of administrative thing, indenting, supply chain management, even maintain of accounts. And unfortunately, we are not trained during our training for any one of such activities where we get thrown into by the system. I remember after doing my MBBS, when we joined armed forces, there was a situation. I remember in my initial internship tenure at Military Hospital Ambala, where we had I was because of whatever hierarchy we have, I was asked to officiate as account officer. And I remember, one of our clerk who was, who used to, at that time, he used to have those manual typewriters, and he used to, while typing, he used to speak also whatever he was typing. So I overheard him talking, copy to accounts officer for unnecessary information. So I confronted him. I said, why you are saying unnecessary information? He said, sir, aapne sun liya. So I didn't want you to hear it, but the fact is that how much do you understand of accounts? For getting a copy of this, and what will you understand out of it? If you have to understand, then you have to at least learn the basics of it. So I'm not saying that we make our medical graduates or we make our professors as accounts officers. But at some level, the training on what they are required to do on the day-to-day basis, managing the account, managing the department, managing the supply chain, soft skills, interpersonal skills, medico-legal aspects of treatment. Maybe a short capsules on that for, depending on the requirement, could be one of the ways forward. And ultimately, the standardization, of course, everyone has to think about it. We are talking about accreditation and other norms. The hospitals are going for it, whether we go for accreditation or not. But at the same time, I think the standardization is something which is going to bring a lot of uniformity, lot of streamlining of what we can get in the form of treatment. So these were some of those very humble thoughts. Maybe, as I said, that I am not deeply into what were KGMU structure and KGMU way things happen. But at the same time, as an independent industry observer, I put my thoughts together and put it across to you. Thank you for the patient listening, and I'll be available for elaborating on any one of these things if so required.
Thank you, sir. You have highlighted well that what strategies we need to adopt to introduce clinical protocols on a national level, as well as managerial skills where we think our medical graduates are definitely lacking. Our next speaker for giving us the suggestions and strategies for developing innovation skills is Professor Rishi Sethi.
Well, a very good afternoon to all of you, and thank you for, sir, and all of you for giving me this opportunity to present my thoughts on nurturing innovation in our medical university. And how do we set targets for the next 5 years till 2027? And essentially, all academic universities are have been traditionally more inclined towards basic core research, and now the time of translational research is arriving, where we have to look for interdisciplinary things. And I think in that context, is my presentation today. So before we go on to the concept of how it is to be done, we should realize why it is to be done. And we are amidst the industrial revolution IR 4.0, which concerns the previous industrial revolutions in the last 150 years have concerns about automation, mass productions, technology, and computer sciences. But now the IR 4.0 that we have entered concerns interdisciplinary research, where different streams of education come together and lead to innovation and lead to more productive ideas, more feasible ideas that leads to sustainability of our research and of our community and our society and our planet overall. So in this context, educational universities form a very unique milieu because they have diversity in terms of different departments. There is a horizontal diversity in terms of various clinical, paraclinical, preclinical departments, core research, as well as clinical material under one roof. And also they have vertical diversity in terms of people, in terms of manpower they are hiring, from medical students to residents to researchers to junior level faculty, intermediate level faculty, and senior professor level faculty, which can be more of advisory and mentoring role. So this diversity in academic institutions provide a very unique milieu for a basic core research to go into a translational milieu, and that's why the importance is towards in university education setting goals and guidelines that lead to these goals. There's also been a little bit of a debate in terms of both universities' focus, any academic institution's focus, as well as funding for the pure core research versus the translational research. Of course, pure research is important in terms of creating hypotheses and helping those technologies and identifying those technologies and helping those technologies go into the translational mode. So it's actually a balance between a pure research, pure core research, as well as the translational research that is the need of the hour. And we need to move from bench to bedside. Both are important, but we need this transition also. As far as the guidelines are concerned, Dr. Sneh Bhargav Committee of 2012 also recognized this fact and said that be it the preclinical departments, paraclinical departments, or clinical departments, up to 10% time of any faculty in the department has to be towards work related to transitional work, corporate and kind of entrepreneurship activities. And that's also one of the guiding principles on which the university should work, and essentially trying to bring everything, summing up everything under one roof. We also have to, since it's a medical university and coming to specifically to our university, we have to realize, we first have to ask ourselves why we are doing this. We have to realize that medical devices, medical technologies are a very, very fast growing market. And till now, they have been dominated by private sector, by corporate, by industry. But nowadays, a lot of interaction in academic institutions, both medical and engineering, globally and in India, is happening in order to help and get a piece of this kind of market share. And that's why it's a 500 billion industry as we are speaking, with a very fast growing rate predicted for between till 2013. Unfortunately, India holds a share, as it was highlighted by the Director IIT in the last presentation. Out of this $500 billion, we share only around under $1 billion. So there is a vast upside, vast upscaling that is possible with our collective endeavors. So this is something that I want to highlight before all of you and sensitize to all of you. Whenever we speak of innovations, innovation cannot be seen in a different isolated silo, which is different. In innovation, when we speak about co-research leading to innovations, so innovations also need to have a sort of an exit and outcome, and that is a product, technology, entrepreneurship journey. So whenever we speak about and this was the discussion we were having day before yesterday, also in one of the meetings here, that should we be promoting only ideas? But actually the thrust has to be the idea in itself doesn't have any value. It may give us self-satisfaction, an outlet to our creativity, an academic outlet to our own emotions. It may also add the maximum, add to our CVs in terms of any publications or patents. But an idea needs to have some journey, some way forward in order for it to be meaningful. And since collectively all of us are sitting together, we need to be sensitized to this idea also. So idea is something that we relate to an innovation in medical universities, but that needs to change. Because when it comes to an idea, everyone will have an idea. When it comes to basic screening and developing how this idea needs to be developed, that is also something that we can do. But whenever we have to take just an idea, we can use it as an academic currency of the university, but at the same point of time, but whenever we have an idea, we have to screen it on the parameters that whether this idea has got a commercial, has got an outlet in terms of commercial or social or academic outlet in terms of a technology or a device or something that's going to make lives of the patients or the hospital or the physician better. So we end up our journey of innovation, and many times at this level only. But if we have to move forward, if we have to convert that idea into a technology, a product, anything, then we have to go for developing proof of concepts, prototypes. We have to go for their IP protections, regulatory approval, how to manage them, techno-legal issues. We have to understand that beyond creating prototypes in academic institutions, be it medical, be it engineering universities like IIT, you can only go up to a certain level creating alpha prototypes or beta prototypes. But when you have to go to industrial level designing and mass production, you have to take help of other specialities in terms of ergonomics, human designing, industrial level designing, and there the role of industry also will come. As when we have achieved this parameter, then we have to come back to the medical university. We have to do, for the regulatory approval, we have to do clinical trials. We have to have process of doing clinical trials of products. Till now, we have processes of doing clinical trials of research, co-research, but we do not have still set up those guidelines in order to do clinical trials of medical technology and products on patients or animal research. And then when everything is done, when we have regulatory and clinical approvals, then probably how do we want to take the technology forward on our own, or do we want to transfer the technology to a larger industry and larger company? And that part is business management, and that also needs to be put into perspective before we think of just innovation. So innovation is important, but innovation needs to have an outlet, and this is a pretty long journey which lasts around 3 to 10 years. So whatever guidelines and roadmaps we set today, we need to have a very long vision, and that will produce fruits a little later, but the fruits will be definitely worth their blood. So another thing is that whenever we think about innovations, whenever we think about developing these relationships with engineering institutions or let's say government bodies or regulatory bodies, we'll think of just an MOU and just a simple handshake. The relationships is not like a simple handshake, because in order to take any idea of innovation forward to the next level, a lot of complex interactions need to take place. And so we have to develop an ecosystem where we have a platform in which medical ideas generation people, technology, creating of prototype people, industry, regulatory approvals, intellectual property lawyers, all these people come together. And then in this regard, we have been having some, background work since 2018. I think all of you are aware of the work that we have been doing. But the fact is that what we have learned out of these last 3-4 years is that medtech innovations and entrepreneurship journey are a realistic possibilities. It's not a far-fetched dream. It's a realistic possibility in our environment, provided we think and work and collaborate meaningfully. The focus has to be technology which are relevant to our need rather than just blank flight of ideas. And conceptualization, the ideation has to be followed up with equal amount of time and dedication and infrastructure backup for execution and to take these ideas forward. So SIB Shine is one such platform that is developing, that is building an ecosystem that identifies, nurtures, and matures the next generation of biodesign entrepreneurs and help develop disruptive technologies, accessible technologies for the world. We have a clinical immersion and creation program that most of you know about. I will skip that. We have selected fellows from all across the country, and we have 9 fellows who are already working. But I would go a little beyond that. And the first part of moving beyond an idea was creation of prototypes and technology support. That would be done probably by our interactions with predominantly first with IIT Kanpur, then going forward with other engineering institutions. The second thing is when we have created those prototypes in technology, how we protect the interest of the innovator that is from KGMC, how do we protect the interest of the university, and that everything has been laid out with the intellectual property policy that was by under the guidance of our Honorable Vice Chancellor. This was a very, very important landmark in which last year that we have published and approved our intellectual property policy, and we are trying to develop mechanisms and SOPs of execution of that IP policy, and trying to develop over the next couple of months workshops and orientations program which will orient the entire university and the students about the presence of this policy and about the nuances of this policy, because a lot of confusions that are in place right now needs to be sorted out, and we'll do this effort in the next couple of months that will follow. So this intellectual property policy has been framed by the top legal intellectual property experts in the country, and it tries to address as many problems and issues that we can we are possibly can foresee in times to come. Of course, there will be some controversies that will arise in future that we will address, but it's fairly comprehensive. It addresses most of the aspects, and it is fairly coherent with the policies of Government of India, All India Institute of Medical Sciences, the ICMR, and in fact, our IP policy was framed by the same people who have framed the ICMR policy, and a little before them also. So the ICMR policy actually also speaks exactly the same language as our own IPR policy. So we have a governance of operation in terms of you have creators from the university, which will be supervised by the Intellectual Property Management Committee, to be chaired at the peak by Honorable Vice Chancellor, sir. Briefly speaking, whenever an innovation comes to happens in the university by any faculty or a research scholar or a student, then the benefit to the university is that university will have the ownership of the IP that is generated, and it could share 20% of any future revenue that is created by this particular technology or device. We have to understand that out of every 500 or 1,000 technologies that we create and talk about, only a very small fractions would ultimately land up in generating revenues. But when and if it happens after 5 years and 10 years, university will have its share back, and it will have a large academic currency, whether it's being translated to revenue generation or not. The university will have ownership of all IP that is created by any employee of the university. So that's the benefit to the university. The benefit for the creator and the ideator from the university, be it the faculty or the student, would be that the university will transfer the right of commercialization of that technology. The person will be recognized as the chief innovator of that. The ownership will be the university. The innovator recognition would be to the creator, and if and when the technology gets transfers, and if any employee gets any revenue benefit out of it, then as for the next 5 years of our duration, whenever we change this pattern, 80% of all future revenues generated would land with the innovator. So that's the incentive to the innovator. Now, Dr. Anita had asked me to be very specific about the goals that we can think, and that the goals to the best of my knowledge and understanding and wisdom, I have tried to give a specific goals for the next 5 years that we can work according to the timeline that we decide, is that we have to create a physical as well as an academic infrastructure to train young generation of innovators in medtech space, be it students or faculty. We already have an SIB Shine program, but we need to build things around which are inherent to the university, not as a collaborative work, but inherent to the university also. One of the ideas is that we can develop an innovation cafe. These cafes are developed even in leading technical companies like Apple or Google. You have a space where people can sit and drink and have coffee at the same point of time. There is basic sort of a Lego structure things that you can create your basic prototype models to just see whether there's a proof of concept is possible. You can have a very rudimentary support for model generation, discussion, some knowledge-based kind of thing, and a basic 3D printing of like under 50,000 3D printers, which just exposes them to the art of kind of taking an idea to a modular form. So that's one thing that we should be looking forward. And another thing is we can have some curriculum changes, that undergraduate teaching in which we can incorporate courses that are related to innovation and entrepreneurship, management, regulatory approvals, intellectual property protections, and things like that. We can hold workshops, orientation workshops, hackathon, let's say one every quarter of a year. So next 5 years, we can have 20 workshops like that will orient the students and each coming batch with the things that we are doing. The IP goals are important and they are a realistic possibility, although they may look a little far-fetched at this present. In the next 5 years, we tend to secure around 100 to 150 significant IP. I would not talk about frivolous ideas only because that's something you can put down on 2 lines on paper and try to. But those ideas that have even a widest imagination possible, some idea of executing at some point of time, but a meaningful IP of around 150, that translates to around 20 to 25 per year. And out of these 20 to 25, overall 100 IPs over the next 5 years, the university, and we in the last meeting, Honorable Vice Chancellor was kind enough to give us a kind of a assurance of a seed money in which 50 of these ideas would be financially and techno-legally supported by the university till the level of Indian patents. And if there are some exceptional ideas that need a little more hand-holding, that we see a value that may have a disruptive technology and we may have a chance to hit the moon in terms of those, I think around 1 or 2 technologies per year can be, we can handhold them even to the international level of patents and even to a little longer, trying to set them collaborations in government sector, regulatory bodies, industries, and so on and so forth. We should be setting up an incubation center. That is a requirement by all the major accreditation agencies. We are thinking of applying for a BioNest of BIRAC, which may happen next year. And overall, be it the university, be it the technologies that are coming out of SIB Shine or inherent technologies that are not out of the Shine program, we should be in a position to create around 15 startup companies over next 5 years. And we should have a structure that supports and that's consistent with the ICMR policy of intellectual property, supporting faculty by formulating policies which are conducive to growth and entrepreneurship, ensuring compliances to rules and regulations, but at the same point of time, cutting across all red tapeism, because that's the basic death valley that most of these innovations end up into, is the death values of red tapeism. Then, of course, there is some provision which ICMR policy talks about. We don't talk about that in our own IP policy, that if there is an exceptional idea that may lead to a company formation of startup, we can think about giving sabbatical leaves for 1 or 2 years to the university. This ICMR policy speaks about for 1 or 2 years in order give them time to take that idea forward. Otherwise, if they keep on multitasking, the ideas will fail. We have to support networking with government agencies, regulatory agencies, patent offices, national and international, and industry collaborations. So this ecosystem would help us develop these 12 to 15 technologies. Computer science and medicine is coming up in a big way. We all like to talk about it. We all like to think about it, but we generally shoot from the hip. We don't understand the kind of groundwork data that is required in terms of electronic data capture in a very, very methodical form, which is congruent with all the international guidelines, and the clinical data storage under one uniform ID for clinical information, for biochemical information, for any biopsy information, and for images that are coming out from ultrasound, CT, MRIs, echoes, and so on and so forth. And pathology images also. So we need to have this background information, baseline infrastructure first, and then we should be setting up a center of AI and advanced computing. Let's not call it only AI and advanced computing in medical sciences. And soon we should be applying for some ICMR or someone to set up this center along with collaboration with big engineering and computer science institutes. And we should be encouraging effective MOUs with international university with a robust innovation curriculum. We should be encouraging industry participation under rules and regulations, but we should be more open to industries coming up, because there is sometimes they can take things to the next level, which only academic institutions cannot. So these were my few. Sorry, I overstepped my time, but I thought I should express my views on this.
Thank you, Dr. Rishi, for highlighting the vast opportunities that we have from going from basic research to translational research and trying to convert them with the medtech innovations. Sir, if you would permit, we also have a few ideas which have been sent to us by the student representative, Shubhajit Roy, who's a student of batch 2019 MBBS.
Sure.
So he has said that the students are happy with the new initiatives of DSW, where they think that it is in the right direction with the mentor-mentee system being implemented, counseling cell and student scheme. And they hope that these are not just one-time activities, but they are taken on further. And research also, they think that the track for the undergraduate that has been developed is very useful to them. And they have also suggested, sir, as far as our website is concerned, that many students are well versed with coding and programming. And they would like a student IT committee to be appointed so that digital and e-work, which is done by the IT cell, can reach to a higher level with the inputs of some of these students who are of this generation and more pro in this field. So that's one of their suggestions, sir. Along with that, the innovation culture also they think has grown in the college, and more students would be inspired by this to become physician scientists, and they would like more innovation workshops and collaboration opportunities. Activities like Shark Tank was held recently in the college, which they think should be more regularized. The previous Vice Chancellor had suggested that MCQ models for all units by each department should be provided to students so that with the changing pattern of exams that they have to clear, it would help them. That was one of the other things, sir. That's all, sir. So I would request you now to conclude the meeting.
Yes, so thank you, Professor Shalini Bhalla. Well, let me begin then by saying that I couldn't thank the quality managers enough for throwing up lots of ideas and thoughts as far as this. When we started off this seminar and this workshop, it was basically to develop some goals till to 2027, and so that KGMU can align itself in its thoughts and ideas and its progress, and with the new education policy, and also with the SDG directives, which is on a larger canvas. This is what the United Nations suggested, SDG 3 and 4, which is health for all, as well as education to become more inclusive, and we in India to perhaps align ourselves with the new education policy of 2020. Having said that, we threw up a couple of ideas. The reason was that we are now in the process of making a vision document for KGMU. How do we take this college university forwards? I'm very happy with the gap analysis, because really it's so important to be factual. It is so important to be introspective. It is so important to have the right data and try and find the faults, and do a SWOT analysis of your weaknesses, strengths of course, but weaknesses, so that you can do a gap analysis and then try and take this forward. So I'm very, very happy as the gap is concerned. Well, friends, ladies and gentlemen, as you're all aware, we talked about various things, whether it was medical education, research, quality, healthcare, entrepreneurship, managerial skills, and innovations. Now, each one of them has thrown up some thoughts, thrown up some ideas, thrown up some issues. And I think what we have to see is, how do we factualize them? How do we try and actually implement them? And I think that is, to me, is going to be an important area to focus on. That is number one. Having put that on the larger canvas, I must admit that we are a public sector hospital, and we would perhaps be somewhat constrained in terms of funding. One could be infrastructure, be it for human resource, be it for infrastructure, and therefore it's a tightrope walk. You want quality, but you are constrained in terms of your resources. So that's the larger picture. But having said that, we should, whatever we have in our at our disposal, let's say CSR for that matter, we should be looking at CSR, we should be looking at extramurals, we should be looking at other portals to help us in our growth story. And I think you'll all agree that growth of any nature of an academic institute, an institution of this nature, is an ongoing story, and therefore we have continued to evolve. We have to continue to grow. These thoughts which have come up in this discussion, I think are required to be tabulated, and I'm sure the quality managers will put this into perspective. And I think with this, I once again thank all the speakers for their very, very valuable contributions. Professor Tripathi, Professor Sheli Avasti, Professor Yashpal Bhatia, Professor Rishi Sethi, and of course, Professor Anita. So I thank each and every one of you for your thoughts, for your very valuable suggestions. Professor Yashpal Bhatia for bringing in some exceptional thoughts from across the world, global thoughts. Thank you very much, Professor Yashpal, for helping us. And we would look up to you for your support from time to time on whenever we have our quality get-togethers. And I really liked what Rishi said about the idea cafes. Ideas, innovations cafes, where you sit down and talk and discuss. And I think one such innovation cafe might be there today evening's New Year Eve's party. So I will conclude my thoughts. Once again, wishing all of you a very, very happy 2023. Thank you very much for being here this afternoon. Thank you, ladies and gentlemen.
Thank you so much.